Monday, April 26, it is 1 p.m. and this is Pospo and BRAINCAST for Mostly Learning for the last session of the month. And whether you believe it or not, it was April 28 when we kickstarted BRAINCAST with 5 sessions of the psychiatry of pandemics. 1 whole year. 43 guests from all walks of science and all levels of seniority, from molecular biology to functional neuroimaging, and from phenomenology to philosophy and sociology. Thousands of attendees from every corner of the world that give meaning to all this. Because the truth is that, without you, nothing would ever be possible. Don't forget that all 43 interviews are there for you to watch on YouTube or listen as podcast on Spotify at your own time. You'd be surprised how well the Greek accent sounds on Spotify. It's beautiful. Thank you all for the heartfelt messages for my newborn son. He's 12 days old and way more mature than I had ever been in my bloody life. Last week, we flew to Toronto, where we met one of the masterminds behind the neuroimaging of cognition, Professor Aristotle Voineskos, Vice President of Research and Director of the Campbell Family Mental Health Research Institute, and a professor in the Department of Psychiatry at the University of Toronto. This week, we stay local, just a short walk down the road, where we meet an outspoken ambassador of all things headache. His papers, letters, and comments a pure joy as he makes highly complex concepts easy to grasp. He's a director of the National Institute for Health Research, Wellcome Trust, King's Clinical Research Facility. He is the national lead for neurological disorders for the Clinical Research Network, a trustee of the Organization for the Understanding of Cluster Headaches, and most probably the best acronym out there, Ouch UK. If that's not enough for you, well, he is one of the 2021 awardees of probably the most prestigious award in our field, the Brain Prize. So, BRAINCAST people, this is Professor Peter Goadsby. So, Prof, welcome to BRAINCAST. As always, let's start with a question that I'm pretty sure have caused you lots of headache throughout the years. So, what is a headache, and what are the main different types?
Well, headache, without wishing to sound too obvious, pain in the head. But I think that's not quite the question that you're asking me. I think that
Can you hear me?
So there's two. If you think about headache, there's 2 types of headache. There's headaches that occur because something's causing them, in the sense of external causes, what are called secondary headaches by the way they're classified in the International Classification of Headache Disorders. Things like meningitis or head injury will cause head pain. If someone hits you on the head, you get head pain, so that's headache. The other broad class are called the primary headache disorders, where headache is part of the syndrome itself. So migraine is a primary headache disorder. There's no external cause for it. And within that broad context, the International Classification of Headache Disorders runs for about 200 pages and discusses a broad range of headache types.
Fantastic. Okay, so then since you mentioned migraines, let's start with migraines. So back in 2015, you wrote a paper for Nature Review summarizing a decade, as you said, in progress of migraine treatments. You start by saying that, one of the main driving factors behind this progress is the realization that essentially migraine is a brain disorder rather than a vascular disorder. So can you explain this to us? So what do you mean by this?
For some part of the 20th century, maybe from the 50s through to the end of the 20th century, migraine was considered to be a disorder of the brain blood vessels, that during the migraine aura, flashing lights and loss of vision, there would be a constriction of the vessel, and as that recovered and dilated, the dilation, the increase in size of the vessel would be the cause of the pain. That turns out not to be the case at all. An important realization, I think, and it wasn't a great realization of the 21st century. The celebrated neurologists of the 19th century, Gowers would be a good example, saw migraine as a disorder of brain function rather than blood vessels. And I think you might say rediscovery of that, reawakening of that, the idea that migraine is due to dysfunction in the brain, which is driving blood vessel changes, as opposed to the other way around, is crucial to understanding how you might think about treatment. If you think that migraine is a disorder of blood vessels, then you do things to blood vessels to treat it. If you think it's a disorder of the brain, then the range of the way you think about the treatment is completely different. The development of the treatment, the understanding of the disorder. So it's quite fundamental to have a construction that fits the disorder.
I mean, in an excellent paper by Kirsty Vetwick for the Lancet Neurology, she explored the sex differences in migraine, and it becomes clear that that women not only are affected more, but also have distinct clinical features and even suffer greater disability from migraines. So, are we looking into, if you like, distinct pathophysiology or the differential effect of sex hormones in these differences?
Well, that's not an absolutely resolved question, but I think that my view is that substantially the difference is the latter, is the underlying physiology being manipulated, if you like, driven, affected by female sex hormones, and particularly the cycling of those hormones. It seems that it's the changes that are quite important. If you look at, for example, pregnancy, for most of pregnancy, migraine improves, and the sex hormone, the estrogen level, doesn't plummet. Quite to the contrary, but it becomes quite stable. I think it's fair to say that it's the exposure and cycling. The most convincing thing for me about this is the person who might start out male, as one might use the term, and then start taking female sex hormones as a transition. And I've seen patients in that situation develop migraine and be stuck with a complex situation, you might say, where they could stop the hormones and have stopped the hormones and improve, but that's not really their desired passage in life. So that they develop it aggravates their headache. I think that's probably the clearest evidence that it's the hormones are altering the underlying, whatever it is that the underlying inherited biology is.
Really, really interesting. I mean, the million-dollar question for migraines, of course, is, why wait for them when you can actually prevent them? And reading the NHS website, on migraines, it seems, to me at least, a bit outdated, as it keeps on with the same old topiramate, propranolol, amitriptyline, and no word about the calcitonin gene-related peptide, the CGRP receptor antagonist. So I'm really glad to have you here, as you seem pretty excited by the possibilities they open up.
Yes. Well, websites people have to curate them and catch up with them, and life's complex. I'm sure the NHS has had a few things to do in the last 12 months.
They have had.
handling other problems. The best estimates are that about 40% of people with migraine would benefit from having a preventive. Where do you get the estimate from? Well, if you look at migraine, there's a range of frequency and certainly a range of disability that's associated with the attacks. Somewhere about more or less one attack a week is generally what we start to think of as being a frequency where things will do better if they're prevented. Now, it's an equation. You look at how easy it is to treat the attack and how and how frequent the attack is. You know, a person who's having 3 attacks a month, none of which respond to acute treatment, might want to talk about prevention. Person having 5 attacks a month who respond to naproxen in 30 minutes, there are people like that, maybe not interested in the discussion if they're not getting any side effects. So how easily you can treat the attack, relatively speaking, is a pivotal thing. There does come a frequency as the frequency drives up when it's actually better to think about prevention. Many people also are interested in prevention because of the predictability that it gives you. So one of the real curses of migraine is that you can't tell on Monday morning, as you start to prepare for the work week, whether Tuesday is going to be a migraine day or not. And so what can you plan? And that disturbing, one of the luxuries I think most people take for granted almost is that coming in the week, you can tell what you're going to do on Thursday. You look at your diary or you know what you're doing. But if you've got migraine, you may not necessarily be 100% sure that that's what you're going to do on Thursday. And that unpredictability is part of the broad disability I think that the problem has when you think about person functioning in their life. And so if you prevention to some extent can provide that sort of predictability. And one of the problems we've had with prevention hitherto is that all the preventives we've had have fallen into migraine by happenstance, you might say. So it was a GP in England actually that noticed patients and reported it, and cardiologists afterwards, who were on beta blockers, on propranolol, whose migraine had improved. Several randomized controlled trials later, that works. And all the things that have typically been used in migraine, beta blockers, tricyclic antidepressants like amitriptyline, drug like pizotifen, drug like topiramate, started somewhere else in blood pressure, mood disorders, in epilepsy, and fell into migraine because they were noticed to work, and then controlled trials were done, and that was fine and dandy. So a huge change is to have medicines that were designed for migraine as preventives, and that's where the CGRP drugs come into play. That's why they're exciting. Is actually having something that was supposed to be for migraine, and actually, oh wow, it works for migraine.
But you know, a common misconception when thinking about prevention in migraines is targeting the migraine triggers. Now, in 2020, Nadia Karsan published a paper at Journal of Neurology suggesting that patient-perceived triggers are essentially early manifestations of the attack, which I interpret as, it doesn't really matter if you stop eating chocolate, your migraine will still happen. Is that so?
Yeah, for most people, you're quite right. It doesn't make a blind bit of difference whether you stop eating chocolate. So the background to that is that before the pain comes, there's a phase of the attack called the premonitory or prodromal phase, where the attack has already started, and it hasn't received the attention that it should, because understanding how it starts is a way of understanding how to stop it. So in the premonitory phase, common symptoms are neck discomfort, concentration problems, tiredness, sleepiness, yawning, craving sweet or savory things, passing more urine, mood change. It also turns out that when we studied it, that light sensitivity, for example, photophobia or sound sensitivity, can occur in the premonitory phase. Now that phase can go on for a day or so, a little bit more before the actual pain starts. So imagine that someone notices light 6-7 hours before. They notice it a bit bothersome. They notice it because it's bothersome. Then they get a headache. And that happens 100 times or hundreds of times. Light, headache, sound, light, headache, light, headache. Well, lights must trigger my headache because every time I notice this light and then I get a headache. And they make the correct association with the wrong causal basis. Same thing for craving sweet things or craving savoury things. There's an interesting, so if you think about those, you can then understand why someone who might think, oh, light triggers my headache. Oh, that's happened hundreds of times. I know that when this light's bothering me, I'm going to get a headache. So if you put the other optic on, if you excuse the pun, you might take it in a different way. Now, we wouldn't say that every trigger is just a premonitory symptom, but the point of the discussion is to pause and say to yourself the question, well, are some of them? Is if I start thinking about my attack, if I start thinking about how I feel beforehand, is it part of that premonitory constellation? Because if it is, then it doesn't matter whether you don't eat or you shut the or you go into a dark room, because the attack already started. And what you're observing is a manifestation of the attack already started, not something you can stop. And if you start to understand that, it's a way of organizing yourself. If you're feeling in the premonitory phase, certainly having a late night, certainly alcohol, not a good idea. If your brain's already ready to have an attack, kicking a bee's nest is not a really smart way forward. So understanding that is helpful, like just practically helpful. Understanding it's useful for understanding the biology as we dig into where attacks begin, which parts of the brain, and it will translate into, there'll be clinical trials this year, in the next year or so, looking at how you could manipulate that by actually trying to treat the attack before the pain comes. There's no reason to have the pain. I mean, it would be best if you didn't. So using what you could call preemptive treatment during this phase when the premonitory symptoms are present. That's really a thing people are thinking about quite a lot.
And Prof, an older, though, highly cited paper by Miatova, Minen, and Jane and P. So they review the complex relationship between migraines and mental health disorders, with several studies reporting up to 10 times higher prevalence of anxiety and depression in people with migraines, and with multifaceted impact on the course of the migraines itself. So psychiatric comorbidities, they seem to increase the risk of development of migraine chronicity, they decrease the quality of life of patients, but also complicate migraine management. So moving past the obvious explanation that having a migraine never made anyone happy, it does seem that there are shared brain pathways. So is that so?
We think so. I think that the evidence that the psychiatric comorbidities is causal for increased frequency and worsening that's a bit complex. But it's pretty clear, as you say, from the population-based work that's been done, that there's an excess of these comorbidities. We think about it at the moment in terms of amines, the chemicals in the brain that in pathways that are shared. So catecholamines like noradrenaline, serotonin, and dopamine. If I said those words to a psychiatrist, they wouldn't be entirely surprised that I'd uttered them if I was in a psychiatry meeting. And if I said them to a migrainologist, they wouldn't be entirely surprised I was uttering them either. I think the comorbidity relates to shared pathways, as you say, shared brain structures that are involved in both disorders. I don't, as you say, I don't think it's that simple that unhappy people get migraine and migraine makes people unhappy. That's a bit, that's not a thing. I mean, there's several ways to reduce that. One is if the randomized controlled trials. If you take SSRIs, for example, fluoxetine, there's a nice randomized placebo-controlled trial to show it's useless in migraine. It doesn't stop people prescribing it, but you know, it's hard, sometimes it's hard to prove a negative, but the study is negative. Yeah. Whereas if you look at messier drugs, meaning in our world, messy means changes more than one chemical in the brain, like amitriptyline. There's some evidence it's useful in migraine. It's actually, the evidence is not wonderful, but there's perhaps two reasonable studies. And I think I've seen many patients, many patients, who you can improve one thing and it doesn't make a blind bit of difference to the other. A good example would be to improve migraine frequency, and it doesn't alter anxiety because the person's anxious anyway. They'll be anxious about something else, which is their biology. No criticism, of course. Now, if you have bad migraine and you have an anxiety disorder, that's not a very good combination. If you have an anxiety disorder and you can't be sure this week whether you'll be able to do the shopping, that's a recipe for a really unpleasant state. So the comorbidity will produce more disability in the individual, no doubt about that. But I don't think that, certainly not, I don't think of them as causally related.
I mean, though, you know, one of the biggest ironies is that the medication that we use to treat headaches are also causing headache, with 30 to 50% of all tertiary headache clinic patients suffering from medication overuse headache. So what do you think are the most common culprits, a common medication that maybe, you know, we can avoid in order to avoid the medication overuse headache?
So medication overuse headaches has had an interesting and bumpy road in some ways. I think it's reasonably widely accepted that there are medications that can make headache worse. I think it's also increasingly accepted that the equation is not just a simple linear equation. So what do I mean by that? You asked me about the worst culprits. The worst culprits are opioid drugs. The codeine would be the commonest one in the UK because you can buy it in a chemist behind the counter. That's problematic. So opioids are the most troublesome. After that, it's pretty clear that triptans like sumatriptan, rizatriptan, elytriptan, naratriptan, almatriptan, frovatriptan, naratriptan, take your choice, are associated with the problem. Probably paracetamol is associated with the problem. Less clear whether non-steroidals are. Probably longer acting ones like naproxen aren't, perhaps ibuprofen is. As you look, it's like most things, as you look at them more closely, the simple you take too many explanation is not viable. So an area we've looked at, just to give you a flavour for what the problem is. If you go to some years ago, we went to a room, and we've been doing some more work with a rheumatologist. If you go to a rheumatology clinic, then there are people who are getting analgesics, paracetamol, non-steroidals, opioids, and so forth, for their arthritis as the primary indication. Now, if you take 100 of them and you ask them, you look at their headache, and they're all taking daily analgesics, and you look at their headache, then only 10% of them will have frequent headache that you might classify as medication overuse headache. So the majority don't. And of the ones who do, they all have a personal or family history of migraine. So there's something about having migraine biology and analgesics that might make things worse. More interestingly, there's 10% of them, and there's another 20% which are using analgesics every day. They have the migraine biology and they don't have daily headache. So that we start to think that the migraineur brings their biology, and some medicines can make that worse in some, maybe about a third, but not in all. Now the problem is we don't know who they are, who they are, and the mechanisms are not as well understood as one would like. So the idea of medication overuse headache is that you take an analgesic. Let's use an opioid as a good example, like codeine. You take it on a certain number of days, typically 10 days or more per month, and that increases the amount of headache that you have and or makes it more difficult to treat with the preventive. Same idea with the triptans. The triptan part of it is falling to pieces as that's better studied. In the main, taking a triptan frequently doesn't seem to stop these newer preventives working at all, which is interesting. On the other side of the coin, it's clear that taking an opioid every day is a way of producing constipation, CNS side effects. You can get habituation to it. Taking a triptan every day is a way of tickling up your blood pressure, perhaps constricting down blood vessels. It's not so there's good reasons not to do that, putting down medication overuse. And then there's this proportion where if you reduce those medicines, you will improve headache. If we'd had this discussion 6-7 years ago, it was medication overuse is bad, you should stop it, and it was black and white. But like most interesting things, it's gotten very grey. So I encourage people to pause and understand that taking something every day is not helpful, or frequently it's not helpful. It means you've got too much migraine, you need a preventive. Do you have to stop it just like that? Well, there are reasons you might want to, and there's a rational understanding that it may actually, that for many people doing that, just that sudden cold turkey stopping, may not make that much difference. It's an area that's in considerable flux. I wouldn't get into a pitched battle with someone who said, oh, you must stop them, but I wouldn't get into a pitched battle with someone who said, no, I'd prefer to take a preventive first, because I think that as we understand more, it's gotten more complex.
Prof, because I am aware of the time, do you have 5-10 more minutes? Are you happy to continue?
Sure.
Oh, fantastic. So while I would love to ask you to be honest about, exploding head syndrome and the primary sex headache and the visual snow syndrome, for which you actually wrote several papers, one of which for neurology in 2020, a man needs to choose their battles. And I would just keep it contemporary. So in a 2020 JAMA Neurology paper, Mao and colleagues reported that 17% of patients with severe symptoms of the virus, they had headache. So is there a COVID-19 headache?
Yeah, well, yes. Headache's a prominent part of the COVID-19 symptomatology. But if I told you that people with a significant infection got headache, I could put anything in parentheses there, and that would probably be accurate. So we certainly see headache in COVID-19. We've seen worsening of migraine with COVID-19. Much of the phenotype, the appearance of the headache is migrainous, meaning underlying activation of migraine. So it can certainly make things worse. There's nothing, as far as I can see, there's nothing special about that. What we're probably going to see, as we've seen with other infections, and the more severe they are, the more troublesome they are, we'll probably see a form of headache that's a daily headache, a frequent headache that is a post COVID phenomenon. Certainly that's something that we've seen with other infections, and I expect that the clinics in the next couple of years will see patients with an ongoing headache after the COVID infection, when their migrainous biology gets activated. So I think we're in for some difficult some difficult periods, and patients are in for a bit of a ride with this.
It will be. I mean, one thing that neurologists and psychiatrists, something we share, something that we have in common, is the frustration.
The brain. You mean the brain?
You mean the brain? Yeah.
We'd be the only two specialties who think we've got ownership over the same organ. It's a pretty silly arrangement.
But
we share a lot.
We share also frustrations, Prof. The frustration that comes with the fact that sometimes our medication, for whatever reason, they may not work. Now, you have talked extensively about the usefulness of transcranial magnetic stimulation as well as vagus nerve stimulation. So is that an option nowadays?
Well, yes, we share that frustration that they don't always work. I think we share the reality that brain disorders are complex. It's a sort of trivial throwaway line, but they're complex. Brain is a very complex thing. We barely understand how simple functions of the brain, less reflex things, less alone the complex things. And I think the frustration, when my fellows tell me it's frustrating that a person's not responding, I point out to them that the actual frustration is for the patient not getting the response. Your job is to work it out. So get a grip. I find what's frustrating is not being able to help people. But I also understand that every time I'm frustrated, there's a person on the in front of me. Well, these days not necessarily in front of you, but most usually in front of you. They've got the problem. So lose the angst and think about how you think it's a very patient-focused, important thing to say. Are there other things? Yeah, I mean, that's the beauty of having these new medicines. There are these monoclonal antibodies that have become available. In the last 5 years or so, we started to use neuromodulation approaches, so changing brain function by external stimulation, using either a single pulse transcranial magnetic stimulator. It has about the same energy as you get in a magnetic resonance image and the tunnel, the MRI, or stimulating the vagus nerve in the neck with non-invasive vagal nerve stimulation. The latter is particularly useful for cluster headache, and NICE has in fact approved that, and it's in one of these new technology arrangements. Yeah, I mean, it's when NICE approves something, you know that it's not just a pleasant thought, because they're very reasonable. I think they're reasonable people doing a difficult job, and they look at the value for money. And if they approve something, it says it's value for money, and that's to stand back and say that's a useful thing. So that's been really a step forward, because you're talking about, with neuromodulation, you're talking about things that are relatively well tolerated and don't come with side effect baggage. So there are very few patients you wouldn't put in an MRI scanner. So there are very few people who've got any side effect issue which will arise from using single pulse transcranial magnetic stimulation. So it's quite exciting to have other ways to manipulate the brain chemistry that aren't medicines. And so in people who get bad side effects, it's something that we're quite excited to be able to offer.
I mean, I was reading a fascinating paper from 2007. It was called Headache Medicine in Brazil. Now, the authors, they talk about, cultural perceptions of what may be causing, but also how they treat headaches. A tribe calls it the monkey's disease, as they feel it originates by the revenge of the killed monkey spirit. And some natives treat headaches with herbal infusions, while the patient's head is washed with shaman's fermented urine. I also can help but notice variations in prevalence across varying cultures and regions, which brings me to my question at last. What is the impact of culture, you think, on headaches?
Yeah, that's an interesting question. I mean, if you take, firstly, there's an impact in assessment of the epidemiology. If you, for example, go to a culture which is male dominated, not an unsurprising feature of some cultures, well, surprising perhaps, but not an uncommon feature of some cultures, and you knock on the door to find out about headache, then the male gives the answers to the person doing the epidemiology. Well, it's going to be incomplete, because because you're not going to get as good a history from the male about the women in the house as you will by speaking to the women. So the culture affects just the basic question of how common problems are. As you say, culture will affect how people deal with problems. I am struck, I have to say, by wherever I've been, by how similar migraine symptomatology is. If I'm in a smaller city in India and talk about light sensitivity, provided it's translated properly, because apart from English, which I'm modest at, no other language I'm useful in at all, but if it's translated properly, everyone knows what you're talking about. It's very boom. If you go to China, they know what you're talking about, and the prevalence rates have apparently gone up in various parts of the world. I think it's simply the ascertainment's getting better. The Chinese prevalence rates are more or less the same as the prevalence rates in England, as they've gone out and asked the questions more. And the global burden of the problem, it's become obvious it's a global problem. There's 1 billion people with migraine in the world. That's probably an underestimate. And that work has been done by getting out into places and asking the question. So I'm not sure that if you ask and you dig into it a little bit, that the prevalences are incredibly variable. There's some variation, which is perhaps biological. And as you say, there's the cultural aspect of how people are seen, how they might complain. The Japanese, for example, are much less likely to go to a doctor with a headache problem than you might imagine for what's a very sophisticated society. And so they would, if you'd have asked the Japanese colleagues 20 years ago about migraine frequency, they'd have said that it was very different and responses were very different. Ask them today, they're less likely to emphasize the difference as people have become more comfortable talking about the problem. So there's that element of how you express weakness, you might say, express migraine, and then of course there's treatment. So if you took things like, the most obvious thing would be acupuncture, which is very much more common in perhaps China than it might be in Birmingham, as an example, which is no criticism of anybody, but simply it's what the culture is used to. I'm not familiar with urinating on the head as a strategy, although life's a complex thing. I will say it's worth saying one other thing, that herbs and local concoctions. Aspirin was discovered from a tree, from the willow bark. It wasn't synthesized in a fancy laboratory. So there are many digitalis. There are many things that occur in nature where where you can use the chemistry itself, or in a derivative way use the chemistry for useful outcomes. So just because it sounds like a slightly offbeat thing to do doesn't necessarily mean that the underlying chemistry is offbeat. It may simply be that the apparent way it's being done is, shall we say, not the usual. So I think it's useful to listen to these things with a little respect. For example, the Native American Indians used to refer to a particular tree as being a headache tree. Sounds like a crazy idea, maybe an odd idea. But it turns out that the sap of it has an agonist at one of the transient receptor potential, TRPA1 receptors, that there's a plausible biology behind understanding that this receptor's in the pain nerve, the trigeminal nerve. So, at one level, the headache tree reminds me, it's illustrative of the fact that it's not always a good idea. In fact, it's usually a bad idea just to look at something and say, well, that's a silly idea and forget about it. There's much to be found by listening to what a different culture says, because they've just got a different explanation for something that is that happens, so to speak. And as you understand things better, you understand the biology, rather like the Greeks and Romans used to think that the sun got dragged across the earth, and that's how the sun changed. As as cosmologists evolve, we understood that better. There's something behind many things, I think. I'm open to listening.
So historically, though, headaches have been used as, if you like, the most common excuse to get you out of difficult situations, a means of escape, if you like. And how can you actually doubt that someone is in pain? Which of course, brings me to the difficulty that we have to objectively measure pain, with, I think, wide-reaching implications both for appropriate management of the pain, but also in conducting research with imperfect measures of subjective experience. Now, Tom Wager in a 2013 New England Journal of Medicine, and J. Jong Lee in a 2021 Nature Medicine paper, they talk about neuroimaging-based markers that essentially provide a brain-based neurologic signature for pain. So how close do you think are we to developing a pain biomarker?
Yes, as you say, pain is, you have the same problem in psychiatry. How do you measure someone's mood?
Yeah.
What's the scale? We have that problem in, as you say, we have that problem in pain. How do you measure light sensitivity, for that matter? What's the scale? Imaging biomarkers are reasonably useful in an experimental setting. We use brain imaging to study migraine, and that's helpful. I think the problem, firstly, they're not particularly good at an individual level. They're useful at a population level, and I think that and they're a little self-referential. So if I'm developing a pain biomarker, the way I do that is get a person to give me a pain rating to do it. And so it sort of goes around a little bit in circles, because you never really get to the external measurement. It's not like measuring blood pressure, where you can get a column of mercury and you can calibrate 100 millimeters of mercury in the column against your sphygmomanometer. So you've got some external reference. Imaging has a self-referential problem. And not to say it's a bad thing. I think imaging is quite important in understanding structures and understanding networks in the brain. But as a biomarker, there are some complexities. I think it's true of, and that's biomarkers in migraine have this problem, that they're referred to the clinical diagnosis. So if you do make some measurement, you say you use the clinical diagnosis as the gold standard, and then it becomes tricky, because you could have just asked the person the questions at any rate. Well, what did the biomarker give you? I think that one of the problems with biomarkers, certainly it's true in pain and certainly true in migraine, I guess it's true in many areas like this, that there's this, it's almost like we don't believe people, so we have to measure something because somehow we don't trust what they tell us. However, the biomarkers are developed by trusting what people tell you. So it's a kind of goes around in circles, and it's aimed, I think, at the sort of person you're just saying, where you think, well, they're using that as an excuse. I don't think about it that way. If someone wants to use pain as an excuse, the better question is, why are they doing that? What's really the problem underlying that? Rather than confrontationally saying, well, you're not in that much pain. Who's to say that? The real problem is, what's underlying that? Is it a migraine that's preventing doing something, or is there some other thing going on? So I don't find second guessing people in that way of challenging them a terribly useful pastime. I do find trying to understand what's going on in the background a useful pastime. Biomarkers will get better as you understand the biology. I mean, it's an obvious thing to say, but look at anemia. You measure hemoglobin. because that's the biology, and you can use that as a marker of anemia because it's actually the measurement. Once we understand enough about the biology of migraine to understand the chemistry, then we could use that as a way of making the measurements. Until that time, it's going to be very iterative, and I think at some level, for some of it, quite frustrating.
And Prof, hearing you talk about, what is actually causing, the headache, I can tell you, you still have time to switch to psychiatry. I love that. I love that thinking. So, final question for the day.
Well, I mean, what's the difference between neurology and psychiatry, apart from I mean, at some level, I think of neurology as being, broadly speaking, two groups of conditions in neurology. There are those that have got what I'll call sort of brain rot, where the brain is degenerating, Parkinson's, Alzheimer's, and there's pathology, and that's very clear cut. And there's disorders in neurology where it's more in the terms of function. Migraine's a good example of that. The brain's normal in between times, or substantially normal, and then you don't perceive light properly. And I call that migraine. I think that in some areas of neurology we have much more to share in the way we think about the biology with psychiatry than maybe people would care to think. And eventually, it's logical for the conditions to these areas of the profession, I think, to merge at some levels, and because being in different sides of the road doesn't help anybody.
So, which brings us to the final question for the day. I mean, you don't need me or anyone to say that, but you have an amazing career. And I'm pretty confident that you would have had the same recognition if you chose, I don't know, to study Parkinson's or, or MS or you name it. Amongst all, though, you chose headaches, which in a recent letter you described as a continued source of medical shame. So
Yes.
why headaches?
Well, I thought it was interesting, I have to say. I mean, I had a good mentor, Jim Lance, and what got me interested in migraine was when I was a medical student. He gave a lecture, and I thought the explanation for migraine was a bit silly. He was a nice guy, and he was willing to let some stupid third-year medical student with a lot of hair and no apparent sense come up to him and tell him he thought that the idea was that his explanation for migraine was a really bad idea. And after I did that, he said to me, "Why don't you come and help us sort it out a little bit by doing like a medical science degree?" And I thought, "Oh yeah, why not?" So I got into it because of good mentorship, and I think you're wrong, actually. I think if I'd have gotten into anything else, I probably would have made a meal of it. One of the other advantages of migraine is that 40 years ago, when I was getting started, much of what we're talking about, almost all of what we're talking about, wasn't done, and so it was a relatively easier ground to till. Whereas people had worked out much about Parkinson's and MS already. It was much harder. So I think that migraine's been a good place to be in because it's been fertile, because the soil was pretty soft to start digging around in. So I attribute good fortune to good advice in life. If you in a career, there's nothing really substitutes for a good mentor, and I had just the greatest mentor.
Amazing, amazing. BRAINCAST people, Professor Peter Goadsby, a true pioneer progressing our understanding of headaches and their effective management. Next week, you're free to do whatever you like. It's early May bank holiday. There will be no BRAINCAST. And the same applies for the week after that, as I will just stay home to enjoy my newborn son. Join me, though, on May 17 as I fly to Montreal's McGill University. My guest has been cited over 43,000 times. He's among the 2020 highly cited scientists, and he has more than 32 career awards, including the prestigious Margolis Brain Disorders Prize and the Colvin Prize for Outstanding Achievement in Mood Disorders. He's Professor Gustavo Turetsky, and we'll be talking about suicide. Until then, Pospo and BRAINCAST for Monster Learning. Over and out.